presentation on peptic ulcer disease. The following presentation will first discuss a case study about a patient diagnosed with a peptic ulcer, and then we will further discuss the pathophysiology of the different types of peptic ulcers, the organs that are most affected by these ulcers, and the best ways to manage a patient when dealing with peptic ulcer disease. We will also discuss what medications are recommended for treating them and what are contraindicated when dealing with a patient who has a peptic ulcer. We will also discuss several of the complications that can arise from having a peptic ulcer and some important facts regarding treatment and patient education that we need to make sure we inform our patients about, especially ones that are prone to having peptic ulcers or have had them in the past. We will start with a case study on Sheila, a 54-year-old female. She is a smoker, a heavy drinker, and works as a 911 phone operator. She works the night shift and drinks a large amount of caffeine in order to stay awake during her stressful job. Sheila has an old knee injury that developed into arthritis and takes ibuprofen 800 milligrams twice a day as needed for pain. For the past 6 weeks, she has been experiencing a dull, gnawing pain and a burning sensation in her mid-epigastric region. It tends to feel better after she has eaten. She occasionally feels nauseous but denies vomiting or any melena. Sheila has a history of occasional heartburn and has been taking Tums several times a day with no relief. The pain has gotten so bad that she decided to go to the urgent care to be seen. Upon examination, the patient's abdomen was soft and non-distended. Bowel sounds were present in all 4 quadrants. There did appear to be some tenderness when the doctor was palpating the epigastric region. All her laboratory findings were normal, so the doctor decided to perform an upper GI series to check for an ulcer. Upon scoping, a 1-centimeter ulcer was noted in the lining of the stomach. Biopsies were taken to check for H. pylori.
Pathophysiology of peptic ulcer disease. Peptic ulcer disease results when mucosal defenses become impaired and no longer protect the epithelium from the effects of acid and pepsin. There are 3 types of ulcers that may occur: gastric ulcers, duodenal ulcers, and stress ulcers, which are less common. Most gastric and duodenal ulcers are caused by H. pylori infection. It is believed to be spread through contaminated food and water, although it is not certain how it is transmitted. As a response to the bacteria, cytokines, neutrophils, and other substances are activated and cause epithelial cell necrosis. These bacteria produce substances that damage the mucosa. The helical shape of H. pylori allows the bacterium to burrow into the mucus layer of the stomach and become undetectable by the body's immune cells. This bacterium does not cause illness in most people. It is a major risk for peptic and duodenal ulcers and gastric cancer. Gastric ulcers usually develop in the antrum of the stomach near acid-secreting mucosa. When a break in the mucosal barrier occurs, hydrochloric acid injures the epithelium. Gastric ulcers may result from back diffusion of acid or dysfunction of the pyloric sphincter. Without normal functioning of the pyloric sphincter, bile backs up into the stomach. This reflux of bile acids may break the integrity of the mucosal barrier, which leads to mucosal inflammation. Toxic agents in bile destroy the membrane of the gastric mucosa. The regurgitation of duodenal contents worsens the gastric mucosal injury. Decreased blood flow to the gastric mucosa may also alter the defense barrier, which allows ulceration to occur. Pathophysiology of peptic ulcer disease continued. Duodenal ulcers occur in the upper portion of the duodenum. They are deep, sharp lesions that penetrate through the mucosa and submucosa into the muscle layer. The floor of the ulcer consists of a necrotic area residing on granulation tissue and surrounded by areas of fibrosis. The main feature of a duodenal ulcer is high gastric acid secretion. In patients with duodenal ulcers, pH levels are low in the duodenum for long periods. Protein-rich meals, calcium, and vagus nerve stimulate acid secretion. Combined with hypersecretion, a rapid emptying of food from the stomach reduces the buffering effect of food and delivers a large acid bolus to the duodenum. Stress ulcers are acute gastric mucosal lesions occurring after an acute medical crisis or trauma, such as head injury or sepsis. Gastritis may lead to stress ulcers, such as a patient who is NPO. They are multiple shallow erosions of the stomach and occasionally the proximal duodenum. Bleeding caused by gastric erosion is the main manifestation of acute stress ulcers. Organ system targeted in peptic ulcer disease. The gastrointestinal tract is essentially a tube that extends from the mouth to the anus. It has generally the same structure throughout. There is a hollow portion of the tube known as the lumen, a muscular layer in the middle, and a layer of epithelial cells. These layers are responsible for maintaining the mucosal integrity of the tract. There are three main functions of the gastrointestinal tract, including transportation, digestion, and absorption of food. Components of the gastrointestinal system include the mouth, esophagus, stomach, small intestine, and large intestine. Peptic ulcers are lesions or erosions that are located in either the stomach or small intestine and usually associated with acute inflammation. A peptic ulcer is an excavation that forms in the mucosal wall of the stomach, in the pylorus, in the duodenum, or in the esophagus. Peptic ulcers are more likely to occur in the duodenum than in the stomach. Because these ulcers usually develop in the antrum of the stomach near acid-producing mucosa, when damage occurs, hydrochloric acid will injure the epithelium. Gastric ulcers may then result from back diffusion of acid or dysfunction of the pyloric sphincter. Risk factors include infection with the bacterium H. pylori, use of drugs, particularly corticosteroids, NSAIDs, and platelet inhibitors such as aspirin or Plavix. Genetics plays a significant number of individuals with peptic ulcers have close relatives with the same problem, suggesting that genetic factors may be involved. Smoking. People who regularly smoke tobacco are more likely to develop peptic ulcers when compared with non-smokers. Alcohol consumption. Regular, heavy drinkers of alcohol have a higher risk of developing peptic ulcers. Mental stress. This stress has not been linked to the development of new peptic ulcers, but symptoms appear to be more severe in people with ulcers who are experiencing ongoing mental stress.
When managing a patient with peptic ulcer disease, it's very important to assess the patient. This assessment should include a description of the pain they are experiencing, anything that may relieve the pain, such as eating or medications, and if they are vomiting and what it looks like. It's also important to inquire about a patient's normal diet and habits, such as drinking or smoking. Patients with peptic ulcers may be experiencing acute pain, anxiety, or imbalanced nutrition. All of these diagnoses can be related to peptic ulcers and are important to address. Some goals that we can help our patients to achieve as a nurse are to relieve their pain and reduce their anxiety. We can also help to educate our patients on proper nutrition and how it is related to preventing further ulcers. We also need to make sure that our patients are aware of possible complications that can arise and how to manage peptic ulcers at home.
Medications used to treat peptic ulcer disease. Currently, the most commonly used therapy for peptic ulcers is a combination of antibiotics, proton pump inhibitors, and bismuth salts that suppress or eradicate the infection. The primary purposes of drug therapy in the treatment of peptic ulcer disease are to provide pain relief, eliminate H. pylori infection, heal ulcerations, and prevent recurrence. A common drug regimen for H. pylori infection is PPI triple therapy, which includes a proton pump inhibitor, such as lansoprazole, plus 2 antibiotics, such as metronidazole and tetracycline. The additional use of bismuth therapy is used depending on the healthcare provider. Bismuth therapy is often used in patients who are allergic to penicillin-based medications. Proton pump inhibitors is the drug class of choice for treating patients with acid-related disorders. Omeprazole, lansoprazole, rabeprazole, and pantoprazole are a few examples. These drugs suppress the HKATPase enzyme system of gastric acid production. PPI triple therapy treats patients with acid-related disorders. It includes a proton pump inhibitor, such as Prevacid, and 2 antibiotics, such as Viaxin and Amoxil. H2 receptor antagonists are drugs that block histamine-stimulated gastric secretions. These drugs may also be used for indigestion and gastritis. H2 receptor antagonists block the action of H2 receptors of the parietal cells, thus inhibiting gastric acid secretion. Pepcid and Axid are 2 of the most common drugs available. Antacids buffer gastric acid and prevent the formation of pepsin. They may help small duodenal ulcers heal, but are usually not used alone as drug therapy. Liquid suspensions are the most therapeutic form, but tablets may be more convenient and enhance adherence. Mylanta and Maalox are examples of antacid formulations. Bismuth subsalicylate inhibits H. pylori from binding to the mucosal lining and stimulates mucosal protection and prostaglandin production.
As we just learned, medications is one of the most important treatments we can provide our patients to treat the ulcer and relieve the pain associated with it. Educating our patients on what to avoid is another way we can help to prevent an ulcer from forming. If a patient has a peptic ulcer or has been treated for one in the past, it is important to let them know that the use of aspirin is contraindicated. Aspirin is considered an anticoagulant and can increase a patient's risk of bleeding if they have an ulcer. It's also important to discuss foods to avoid. Any food or beverage that contains acid-enhancing caffeine, such as soda, tea, coffee, chocolate, and even decaffeinated coffee, should be avoided. These foods all have the potential to upset the gastric mucosa and prevent ulcer healing or recurrence. Smoking can also interfere with ulcer healing, and patients should be referred to a program to help them quit. If certain lifestyle changes are not made, it is very possible that a patient's ulcer can cause additional complications. If bleeding from the ulcer cannot be controlled, then a patient may begin to hemorrhage from the ulcer. They would show signs of cool skin, confusion, tachycardia, labored breathing, and possibly blood in the stool. Perforation or penetration may also occur if the ulcer erodes through the stomach tissue and leaks into the peritoneal cavity or adjacent structures. This would lead to severe abdominal pain, a rigid and tender abdomen, vomiting, elevated temperatures, and an increased heart rate. Pyloric obstruction can also occur, and this is when the area by the pyloric sphincter becomes scarred and stenosed with edema or scar tissue and prevents food from leaving the stomach. A patient will usually begin to have nausea and vomiting and be unable to hold food down. All of these complications would be considered medical emergencies and would need to be treated immediately. That is why it is so important for our patients to understand the complications that can arise and what signs to watch for that would require them to return to the hospital. In conclusion, our patient Sheila was diagnosed with a peptic ulcer related to an H. pylori infection. Sheila was treated with a proton pump inhibitor and 2 antibiotics. We stressed the importance of finishing the entire course and rechecking to make sure the infection was gone before stopping medications. We then created a long-term management program to help prevent the recurrence of her peptic ulcer. Sheila met with a nutritionist to create a diet plan that was more appropriate for her condition. She is working on cutting back her alcohol and caffeine intake and is starting a smoking cessation program as well. Unfortunately, Sheila is unable to quit her stressful job, but she is starting to implement stress relief measures such as yoga and meditation to help long term. Overall, Sheila is making the necessary steps required to reduce or prevent peptic ulcer recurrence. Thank you.